So let me introduce our speaker. Dr. Carolyn Coker-Ross is an internationally known author, speaker, expert, and pioneer in the use of integrative medicine for the treatment of eating disorders, obesity, and addictions. She is a graduate of Andrew Weil's Fellowship Program in Integrative Medicine. She is the former head of the Eating Disorder Program at internationally renowned Sierra Tucson. Dr. Ross is a consultant for treatment centers around the U.S. She is the author of 3 books, including one of the first books on binge eating disorder, the Binge Eating and Compulsive Overeating Workbook, and a recent book, the Emotional Eating Workbook. Her newest book, the Food Addiction Recovery Workbook, will be released, was released September 1st, 2017. By the way, Dr. Ross's books are for sale in the back, outside in the hallway, and she'll be, I believe, signing them at the end of this lecture. Dr. Ross currently has a private practice in Denver and San Diego, specializing in integrative medicine for treating eating disorders, addiction, mood and anxiety disorders, and obesity. So we're proud and pleased to have Dr. Ross here, and let me introduce her. Thank you.
Thank you so much. Good morning, everyone. Can you hear me okay? Yeah. Okay. So I actually work almost equally in the world of eating disorders and addictions. I actually am a Suboxone prescribing doctor and have been using Suboxone for medication-assisted treatment from over 10 years, from back in my time when I was at Sierra Tucson. So the reason I have chosen to specialize in both is that, as you probably know if you work in the field, many of the same causes lead to either eating disorders or addictions. And today, what I really want you to take away from this talk is a different understanding of how addictions and eating disorders come about. Because I think if you are in this field in any way, you've seen the same kinds of things that I've seen, where you work really hard with clients and oftentimes they relapse, or there are other problems that come up. There are family of origin issues that come up. And so integrative medicine really gives you a kind of a structure that you can use to understand these troubling questions and problems that we have in this field. So that's what I'm hoping to leave you with, is a little bit different structure than what you may be used to. So you've seen, these are the shameless plugs for my books. Other than that, I have nothing to disclose. So first, let's talk about eating disorders. Michael Pollan, who you know is a renowned author, has said that America has a national eating disorder. And when you think about it, it makes sense, because you can see that Americans are eating more and more, and we're enjoying it less and less. What's interesting is there was a study done of people in the U.S. and then several other developed countries, and that's what they found, is that Americans are cleaning their plates like our mothers taught us to do, but we don't have the same joy in eating that people in France or Italy have, for sure. As well, 30 million people in the U.S. have some form of an eating disorder, and we're going to talk about the different categories of that. And every 62 minutes, so before we finish this conference, at least one person dies from an eating disorder, because eating disorders have a higher mortality than any other psychiatric diagnosis, whether that be addictions or depression, etc. And then when we look at addictions, we know that, just at least half of the people in this room, half of all Americans, have a family member or a close friend who's been addicted to drugs. So addiction, just like eating disorders, does not discriminate. In the past we used to think, well, eating disorders is for, white women or girls from upper middle class families. And now we know that Latinas, African Americans, boys and girls, all socioeconomic groups do experience eating disorders, and the same is true for addictions. And we're going to be able to understand that with that context that I want to share with you. So over 20 million Americans over the age of 12 had a substance use disorder in 2016. We know that there are 2 million people struggling with opiate addiction and 15 million struggling with alcohol use disorder, which remains the #1 addiction. And then just look at the overdose deaths that we've seen in 2016. And I just compare those to the casualties in the Vietnam War. And in 1 year, we've lost more young people and older people than we lost in the Vietnam War. So the deaths from illicit drugs here, that involves heroin and non-methadone synthetics. And the highest rise is from deaths associated with heroin. As you have probably been hearing in the media, a lot of people start with prescription pain medications, and then they move on to heroin because it's so much cheaper. But there was a 6.2-fold increase in mortality from 2002 to 2015. And it's shocking to me that we have, while all of us are doing the best that we can on the front lines, that we don't have a national policy or a national movement to stop this incredible epidemic. Every day, more than 90 Americans die of opioid abuse. And this just shows you the graph of the increase in opioid deaths by year, with the last year being shown as 2015. And you can see that the red line going through the bars is for men, and then the yellow line is for females. So there are more men who are dying than women, but there are a heck of a lot of women who are dying in this epidemic as well. And sadly, for both eating disorders and addictions, now this slide mainly deals with addictions, but the same is true for eating disorders. We have a lot of people who are needing treatment, and we have some great centers who are trying to provide that. But we are, as a nation, falling short in the number of treatment options that we can offer people with addictions and eating disorders. So this statistic is from 2013. An estimated 22.7 million Americans, or 8.6%, needed treatment for a problem related to drugs or alcohol, but only about 2.5 million, or less than 1%, received treatment. Less than 1% of people who need treatment are getting treatment. So here is the most important slide in my slide deck. And I don't want you to bother reading the whole 2 paragraphs. I've highlighted the important things there. The most important thing to recognize is that addictions, and you can say the same for eating disorders, are chronic diseases. Both are chronic diseases. So any chronic disease, whether it be diabetes, hypertension, etc., any chronic disease, including addictions and eating disorders, have relapse and recovery cycles, relapse and remission. So no matter how hard we try, we have to accept that relapse is part of this condition. But secondly, again, addiction is a primary chronic disease, but it's not a disease of willpower. It's not a disease of moral failing. It's a disease of brain reward, motivation, memory, decision-making, and related circuitry. So essentially, it's a brain disease. So until we really get a handle on and accept the fact that this is a brain disease, and I'll show you how the brain disease develops. There is so much research on this right now that you really can't ignore this fact. But what we're not doing is translating this research into our practice. So if it's a brain disease, then how do we heal the brain? And can we heal the brain? So I heard one National Treatment Center owner say that his goal was to help people find the willpower to stay abstinent from drugs and alcohol. If this is a brain disease, and this quote is from the National Institutes of Drug Abuse, NIDA, which is part of NIH. If it's a brain disease, how is willpower going to work? If it's a chronic disease, we cannot be dependent on the 30-day cure. Obviously, there are some people who are so acutely ill that they do need inpatient care, but I think it's really important to note, if it's a chronic disease, we need longer treatment, which it sounds like the Thelma McMillan Center has recognized. Longer treatment for people involves them being able to afford it, them being able to access care while they're working. Not everybody can leave home and go to a 60-day, 90-day, et cetera program because most can't afford it. So I think the sooner we're able to really translate this important information into what we do on a daily basis, the more effective our treatment will be. So let's talk a little bit about the brain. Okay, so the brain continues to develop, as you know, through adulthood. The mature brain regions on this slide are seen in blue. So you can see it's not until the mid-20s when the brain becomes more fully mature. And that little red circle is circling the area called the prefrontal cortex. And that's the area of the brain that governs judgment, self-control, and that is the last part to mature. So is it any surprise that teenagers and young adults whose brains are not mature do not have the self-control and the judgment to resist peer pressure, etc., and to fall into drugs or eating disorders? So the teenage years are really critical. It's a vulnerable time for teenagers. And unfortunately, we don't really get any access to them until they're already sick. But one thing we know about the brain is that it's malleable. The term that applies to that is called plasticity. So the good news is that the brain can recover. The parts of the brain that process reward and pain, those are the crucial drivers of what we're dealing with. So just keep that in mind. The adolescent brain is often likened to a car with a fully functional gas pedal, which is the reward system. They know how to put on the gas, but weak brakes. They don't know how to stop. The brain is not fully mature enough to know how to put the brakes on. So in this slide here, you could put any drug under here. This study happened to be done with people who abuse meth, but you have the same exact picture for opiates, for alcohol use disorder, etc. So what are you looking at? Well, look at the normal control on the left, and you can see, let's see if I can, didn't want to do that. Here's the pointer. You can see here these red areas. That's the dopamine reward center, and that's where dopamine is being produced. So when you see that the red, dopamine is the drug or the substance of reward in our brain. It gives us pleasure when we experience any of the things that give us pleasure in the world, whether it be music or the love of a child or sex or gambling or addiction, etc. So what I'm going to be talking to you about is how a normal control that you see here for someone who is a drug or alcohol, struggling with drug or alcohols or eating disorders may not be as normal as we once thought. And I'll tell you why. But look at what happens when they start using. So it already may be impaired. We know from studies that people who have the dopamine DRD2 gene and a specific form of that may have fewer dopamine receptors. So right from the beginning, their brains may be different than someone who doesn't have that gene, and that then could put them at higher risk for impulsive and compulsive disorders. But once they start using, look how the dopamine decreases. And notice how long it takes, 2 years, for the dopamine to approximate normal again. So what are we doing when we put somebody into a program for 30 days and then say, okay, you're fixed, see you later? What are they going to do for those 2 years? Is willpower going to see them through 2 years of not feeling normal, 2 years of feeling as if the things that everybody else is enjoying, they're not enjoying, 2 years of white knuckling it? We know that that doesn't work. Okay, so where does the problem really begin? Well, this is why I want to talk to you today, because I think what's really important for us to understand is that the problem doesn't begin when they first start using drugs. That's when we see them, but that's only the tip of the iceberg. The problem actually begins even before they're born. So the mother who is pregnant, her behaviors affect the child's brain growth. So things like eating junk food can predispose to obesity. Malnutrition can change the brain's maturation. And again, particularly affecting that part of the brain that has to do with memory and judgment, etc. Also, prenatal stress. So obviously, we have stress every day, but we're talking about mothers who have extreme stress, domestic violence, for example, or living with a spouse or a family member who is addicted or has mental illness. That kind of stress also can really affect the infant. And then attachment issues. I think we're all hearing more about that. But attachment issues really start earlier than we often think of. And these interactions, particularly right after birth, between the mother and the infant, really change the way the brain is wired. So I'm going to talk a little bit about that as we go along. But I just want you to remember, attachment issues immediately after birth change the way the brain is wired. And then stress to the infant or the child whose brain is maturing and developing, again, it doesn't just make them feel bad, it changes the way their brains are wired, because this is the time up to age 3 when the nerve cells in the brain are connecting in a certain way that will either send them down the road of high risk for addiction or not. Uh-oh, I'm losing my clicker here. Can you advance that? For some reason it's frozen. There we go. Okay, so after birth, we'll talk about how the brain responds to childhood experiences, to diet, and also to life stressors. We'll talk more about attachment disorders, genetics, personality. In particular, culture and the media have a strong influence on the development of eating disorders. But we hear that a lot. But the question is, why can 2 little girls be exposed to the exact same degree and amount of cultural ideals of thinness, but one develops an eating disorder and the other one does not? And again, it has to do with the brain and that prenatal and early childhood wiring. Undernutrition and malnutrition that has effects on the brain, and then the chronic activation of the stress system, the fight, flight, freeze system throughout early life, and then sleep disruption. So just think for a moment of a couple of patients that you may have seen with an eating disorder or an addiction. And ask yourself how many of them have had issues with this list. How many of them were born to parents who themselves have addictions, and therefore they're adult children of alcoholics, or their parents were opiate or meth addicts? How many of them suffered trauma when they were younger? How many of them, had a lot of genetic risk? So when you think about that and you realize that all of these things have one effect, and that's the effect on the brain, it makes a lot of sense what I'm saying. So in terms of attachment, we know that relational trauma, again, disrupts the brain's wiring, and it particularly has an effect on emotional regulation. So that's why using techniques to help our clients really become more emotionally regulated, whether it be DBT, CBT, any of the T's will help. There's a lot of them. But you can see why that's important, because this relational trauma, again, affects the brain. Once the brain is affected, then it affects the stress system. Once the stress system is affected, then it feeds back to the brain and the body, etc. So attachment relationships, whether it be that early attachment, if we can mimic it with attachment in therapy, are paramount to the development of the self and of emotional regulation. Okay, so as you know, attachment is one part of the child-parent relationship. When there is healthy attachment, the child feels safe and secure. How many times does that happen? Less and less. Look at it's very poignant to me when I go to Starbucks and I see a mom with a toddler who's on her phone while the toddler is doing what? On their phone, or just staring into, on their pad, right? They have their own pads now. On their pad, or just staring into space with nobody to attach to. And I know that we don't think about that as busy parents. We just need a break, or we need to catch up on our work, or we need to make sure that this email gets answered by a certain time. But all of these are moments of attachment. Babies attach to people who are sensitive to them and responsive to them. That's why babies like grandmothers. I'm happy to say I'm one. So this all needs to happen before the age of 3, because that's when the important brain wiring and connections are formed. So if someone has a secure attachment, that's wonderful. If not, they can go one of two ways. They can downregulate, and those are the patients we see who are very avoidant, sometimes antisocial, they're isolating socially, etc. Or they can upregulate, and they become resistant or ambivalent. Okay, so I know this is kind of an overwhelming slide, but let's just look here. Most of you probably know that at least 65% of kids have a secure attachment or something close to it. About 20% have avoidant, 10 to 15 ambivalent, and the same amount with disorganized, which is the most difficult. Now look over here. If there's secure attachment, as I said, they have trust. They believe their needs are going to be met. If they have avoidant attachment, in the back of their mind, they really realize that their needs probably won't be met. Ambivalent, they recognize they can't rely on the people in their lives. And disorganized, severely confused with no strategy. So they try one thing like acting out, thinking maybe that will get their needs met. Or they try withdrawing, maybe that'll get there. So they're all over the place. So how many of your patients fit into one of those categories when you're working with them and trying to build trust in the therapeutic relationship? How many of them react in this way. The same goes for eating disorders. With avoidant attachment, the child grows up in an emotional desert. They're not in touch with their body sensations. So we see this a lot, particularly in anorexics, where I would have a patient sitting across from me, and they'd say, "I'm so angry at my mother. I just can't believe what she did, and she's always bothering me," and blah, blah, blah. And I would say to them, just tell me, where do you feel that anger in your body? "Well, yesterday she did this and she did that." Okay, I got it. But where do you feel that anger in your body? "Well, I just can't believe that this has been going on for so long." Cannot connect to the body. So that's a form of this kind of attachment issue that I'm talking to you about. Ambivalent attachment, the child grows up in an emotional fog, like everyone around them is a drama king or queen. Their emotions and body sensations feel overwhelming. So they just shut down when they have emotions because they can't handle it. And then the disorganized attachment is where you get the DID and disconnection. Their body sensations and their emotions are associated with memories that may be triggered by what's going on in the environment. Just micro events in the environment can trigger flashbacks of trauma and loss and cause them to dissociate. Even if they haven't been diagnosed with DID, there still may be that dissociation. So let's just go a little bit deeper. I know this is kind of heady stuff, but there's going to be lighter stuff coming really soon. If addictions and eating disorders could ever be light, I don't know. Not sure about that. But remember we talked about the three brains on the scan, and we talked about the dopamine in the red. So that was the reward center of the brain, which has a couple of functions. First, an area that has the prefrontal cortex, and I think I mentioned, is where judgment, thinking, executive function, decision-making happen. And then the limbic part of the brain, which is where emotion, memory, and impulsivity happens. So I talked about the brain being malleable, you can change it, and I talked about age 3. Neglect in the childhood brain also affects brain development. So what you see, and again, compare this to your typical patient. You may see a 10-year-old or an 18 or 20 or 30-year-old may have the speech and language skills of an 8-year-old, the social skills of a 4-year-old, and the emotional regulation skills of a toddler. They're ready to throw a tantrum in the middle of the aisle in the grocery store at any moment. So how many of your patients have that, disconnect between their age and their thinking processes, their emotional regulation, etc.? I mean, for me, it's almost 100%. So it's really, really, recognizing this makes it a little easier, because otherwise you're just sitting there thinking, well, all I said was such and such. I didn't say anything offensive or upsetting, but this patient stormed out of the room. Well, emotional regulation skills of a toddler, even though they may be in their 20s or even older. So the effect of neglect on the brain, here you're seeing these images are a CT scan. The one on the left is from a healthy 3-year-old with an average head size. The one on the right is from a 3-year-old who is suffering from severe neglect. So you can see the brain is smaller, there's abnormal development of the cortex, etc. So children whose mothers nurtured them earlier in life have a larger hippocampus, and that's the part of the brain that is associated with learning, memory, and response to stress. The hippocampus. So mothers nurtured them early in life. They have a larger hippocampus and a healthier brain. So let's talk a little bit about genetics. We know that for eating disorders, There's a high level of hereditability, and particularly for anorexia. Those with a mother or sister who had anorexia are 12 times more likely to develop anorexia and 4 times more likely to develop bulimia. So their risk is high because of genetics. For alcohol and drug addiction, 50 to 60% hereditability. For binge eating disorder, we think around 57%. And then for obesity, compulsive overeating, 40 to 70%. Did you guys know those? Did you have a feel for those statistics, or are you surprised? Okay, so you know that there's genes play a big role. Okay. How many of you are familiar with the ACE study? Okay, more and more each year. I've been talking about this for probably as long as, I think this is one of the coolest studies that's ever been done. It was done in San Diego at Kaiser Permanente, started by Vince Folletti. Now the Centers for Disease Control have taken over the study. And basically what he did, he has about, did I say 17,000 people? But anyway, what he did was look at people and identify adverse childhood experiences that they've had. And these could be experiences like, I had a mother or father who was incarcerated, or a family member who's incarcerated. Physical, emotional, or sexual abuse. Neglect, either emotional or physical. A parent with a substance use disorder. Divorce or separation. Domestic violence that they witnessed. And a family member with depression or mental illness. Now, interestingly enough, the more adverse childhood experiences that the adults recounted, the higher their likelihood was for impairment in social, emotional, and cognitive ways. High-risk behaviors, whether it be sexual behaviors or, other risk-taking behaviors, such as the use of drugs and alcohol, and different medical diseases, including things like COPD and autoimmune diseases, and even early death. So they are continuing to collect data on that. And basically, what I wanted to kind of move to is recognizing that trauma, we talk a lot about trauma, and when I started out, we didn't really think about trauma other than like, someone beating you up or sexual trauma or things like that. But I love this new definition by Gabor Mate. And he says, trauma is defined as the loss of some essential part of you, like a sense of peace, vitality, or presence, or safety, or trust. So when you think about that, you can really recognize that there are so many ways in which that can happen. Betrayals, even in the in jobs, or betrayals in relationships, but as well other kinds of traditional traumas that we think about. So addiction and eating disorders really have their root in this childhood trauma or adverse childhood experiences.
Excuse me, what are scientific gaps?
The scientific gaps are where they're doing more studies to prove the connection between these different things. So they're really kind of breaking it down, but let me tell you what they've found so far, and you'll see how far they've come. So compared to those who have no adverse childhood experience, those who've had 4 or more adverse childhood experiences were 2 times more likely to smoke. Did you think your smoking risk might have to do with childhood adverse experiences? 12 times more likely to have attempted suicide. 7 times more likely to be alcoholic. And 10 times more likely to use intravenous drugs. So, that's pretty amazing to me that, surely we know that people who've been, sexually abused as a child are going to land in our practices. But also, these other people are going to land there too. And so I think it's just important that we be more aware of that. So he started out this project with people who were seeking to lose weight. And what he found was that he had more dropouts in those who were actually being successful at losing weight. And what he said is he learned that many had been unconsciously using obesity as a shield against unwanted sexual attention or as a form of defense against physical attack, and that many of them had been sexually and physically abused as children. So although obesity was conveniently viewed as the problem, it was often found to be the solution, which was unconscious to them, for other, far more concealed problems. Does that make sense? Yeah. And you could apply that to addictions, other eating disorders, etc. Depression often has the same links. So what I'm trying to do is to build just a case for you, a platform for you to see what's beneath the surface of the iceberg. Yes, the addiction is what gets our attention, but underneath the surface are these adverse childhood experiences, prenatal trauma, the loss of a sense of self, the attachment issues. That's what's underneath the surface. So what happens to someone who's had adverse childhood experiences and attachment issues is that their stress system has been triggered. So you'll find that many of them have hyperactive stress responses. So I'll tell you about a patient that I had when I was working at Elements in Tennessee. And the patient was in a little group that I was running, and we were talking about triggers for relapse, a common topic. And he said, oh, I have a trigger that everybody would have relapsed on if they had had it. And sure enough, he talked about a pretty serious thing. He had gotten out of rehab, and his house had burned down. Yeah, that's a big deal. And, everybody in the group was like, yeah, that's really rough. So, of course, the first thing that he did was what? Have a drink, or in his case, use Coke. Now, if you're not an addict, just give me one thing you would have done once your house burned down. What would have been the first thing you would have done if you're not an addict? Call the insurance. Start working on getting your housing for yourself. Call your family and friends so they won't worry about you, etc. So that just, to me, is a stark reminder of how different the brain of the addict and the person with eating disorder is from someone who doesn't have that genetic, adverse childhood experiences, attachment, etc. issues. The brain is wired differently. What seemed normal to him was that he would take a drink or go and snort Coke. But it was normal to the brain that had gone through those things. All right, so again, attachment issues has a lot of power in protecting from and healing the body and the brain when there's been stress or trauma. Life is full of stressors, and life is full of trauma. I mean, most of you here, like me, have had loss of loved ones, loss of job, financial stressors, having to move, etc. But, we don't all go in that same direction. So I'm trying to help you understand that it's not that the person chooses. They're not choosing to destroy their lives. It's that their brain is wired in that way. And that's what's important. Okay, so we know that the lower brain is responsible for the stress, production of the stress hormones like adrenaline, noradrenaline, cortisol. Insecure attachment makes it harder to recover from abuse, neglect, and trauma, and makes you more vulnerable to future stress. So let's look at some of the studies for that just quickly. Women with major depression, 6-fold increase in release of those stress hormones in response to stress. Look at scans of women who have major depression and severe physical or sexual abuse in childhood. Again, changes in the limbic system. Do you remember the limbic system is involved in emotional regulation? So change in the limbic system and a hyperactive stress response. Similar findings seen in people with borderline personality disorders who have been abused or diagnosed with PTSD, increase in stress hormone productions. And once you're producing a lot of cortisol in response to stress.
Here's what I found on the web for OK, so we know that.
That's Siri. She just does her own thing. I don't know what's wrong with that girl. Anyway, cortisol production is implicated in the development of depression and anxiety. So the higher your cortisol levels, keep this in mind, the higher your cortisol levels, the more likely you are to have mood and anxiety disorders. And I'll show you a little bit more about that in a minute. Okay, so what are other things besides, well, these are all stressors, but what are other things besides what you normally consider to be stress will cause cortisol release or cause those stress hormones to be released? First of all, you know what that is, right? The 12-step diet. I think you can see it right here. That's coffee and sweets. That's a really stressful thing for your body to handle. Infections, environmental chemicals, we're finding more and more toxins in the environment that actually are what we call obesogenic. They cause obesity. So now when we're talking about eating disorders, we have to include understanding that some types of toxins can promote obesity. Caffeine is a stressor on the body. And then we know that stress increases your risk for obesity and certainly for binging on comfort foods. So the hyperactive stress response comes from attachment issues and adverse childhood experience. Remember, the brain is, I think I'm hammering this in enough, right? Brain development is altered by these adverse childhood experiences, which causes a kind of chaos in the brain that we don't see without that. And then the lower brain functions, the limbic brain, the kind of reptilian brain that governs emotions, they govern eating, self-soothing, self-harm. Those functions are affected as well. And so people use food, substances, cutting, etc., to regulate their feelings. They're regulating their stress hormones. They're trying to self-soothe. They just want to feel normal. That's one of the things I love about medication-assisted treatment is once you get somebody on the appropriate dose of Suboxone, the first time they are on that dose, they'll come back to you and say, I feel normal for the first time in X amount of years. So that shows you how the brain has been affected and impacted. Okay. Attachment styles and ACEs also make people more sensitive to media images associated with destructive coping mechanisms and negative body image, and people are more easily overwhelmed by stress, and that, as the CSAM has said over and over, stress is the #1 cause of relapse. So if you're unable to cope with stress, if you're easily overwhelmed by stress, that increases your risk of relapse. Okay, so remember the red spots in the brain scans of the meth user. Now I want to dive a little bit deeper into that. How many of you have heard of reward deficiency syndrome? It's a term that's been around for over 20 years. How many have heard? Okay, great. So Kenneth Blum is a researcher who was involved in the discovery of the DRD2 gene. And I'm not going to go into all of the things that he did, but he's written over 40 papers about this. And he really believes that gene predisposes people to a higher risk for impulsive and compulsive disorders. And it causes what he has coined the phrase reward deficiency syndrome. So I mentioned to you, if dopamine is reduced in the brain, either from chronic drug use or from genetics or from adverse childhood experiences or from attachment disorders, then they are not going to have the same amount of dopamine being produced as someone without those issues. So some of the causes, well, let's look at some of the symptoms. After recovery, they may continue to be restless, anxious, depressed, feel empty, lack of satisfaction, and have vague or specific cravings, like for alcohol or drugs. Some of the causes, genetic causes. We talked about genes. Prenatal conditions, again. Malnutrition and severe or ongoing stress. Physical trauma to the head. How many of our kids are now having concussions and have been from sports that we're not paying attention to? And I have a personal story with that because my son chose to do boxing and rugby in high school. And I said to him, couldn't you just pick one that doesn't hurt the brain, just one? I mean, it's going to be bad enough. So he had several concussions, which have affected his memory long term. Yeah. And so, you know, I think we need to look at how can we protect the brain in these sports. But heavy and long-term use of drugs and alcohol, self-medicating, and then I talked to you about a person feeling normal. Sometimes when someone takes their first drink, they say, I feel normal. And then intense pleasure and euphoria that they get initially when they start with addiction. So these are some of the integrative ways in which we can help people with reward deficiency syndrome. And Kenneth Blum has done a number of studies. He has been working on a formula for addiction for, I don't know, over 10 years since I've known him. I don't think he's quite made it there yet. But he did find that obese patients who had gone through those extensive low-calorie diets, OptiFast, where they have like 500 calories a day, they were able to stay in recovery from their obesity and not regain as much weight, not binge on a formula of amino acids to address reward deficiency syndrome. So these are some of the symptoms we'll see in people maybe right after recovery when they stop using and they continue to have anxiety and sensitivity to stress. These particular amino acids, and amino acids are supplements you can get over the counter. They come in foods that have protein in them. So amino acids are the breakdown products of protein, and they are what the brain uses to make serotonin, dopamine, norepinephrine, epinephrine, etc., that we have based the medications on. So you'll see that in a graph soon. But so these are some of the things. You may have heard of tryptophan, which we also use for sleep and cravings. Tryptophan is the precursor for serotonin. GABA is the anti-anxiety amino acid. L-tyrosine is for people who have low energy and poor concentration. This breaks down into epinephrine or adrenaline that are in medications like the SNRIs, such as Cymbalta, etc. And then this is particularly for opiate addicts who have a hypersensitivity to emotional and physical pain. So that's one of the characteristics you may have noticed in patients who are attracted to the use of opiates. They don't like pain of any kind. So DL-phenylalanine is what we use for them. Insomnia, mentioned here, 5-HTP comes before tryptophan, which then leads to serotonin and melatonin. Cravings, we use these. And depression, we use the L-tyrosine. So just see if you can start thinking about, I'm hoping you can start thinking about how do we connect the dots here. We have someone who may have genetic risk. You know, they come from a family of addicts or alcoholics. Then they're exposed to adverse childhood experiences. They have attachment issues. And then there may be other factors that are included as well. But that's what leads us to addictions and eating disorders. So, you know, and obesity. All of those lead in the same direction, and they lead us to the patients that we're seeing in our practices today. Okay, so substance use disorders versus eating disorders. Reward deficiency syndrome is present in both. Cravings that come from this reduction in connections between the hippocampus and the prefrontal cortex. Food cravings, you may have heard a lot in the media about sugar addiction. That's a big fad now. It's one of the big fads. Where would you put sugar addiction after hearing what I'm saying today? What would you say about sugar addiction? Do you think sugar is addictive for everybody? Yeah. So who would it most likely be addictive for? People who have the gene, the DRD2 gene, people who have high ACEs, people who have attachment issues. Those are the people who are more likely to have vulnerability to things like sugar addiction. Just like they have vulnerability for alcohol and drug addiction, obesity, and eating disorders. Okay, let's see. Do you guys feel like a break, or you want to power through for 10 or 15 more minutes? You want to have a break? Okay, so it is 10:05.
10 minutes, is that okay?
10-minute
10,
break.
15 back here.
Thanks. Okay, let's power on to the last half here. So I'm going to just do some quick definitions. How many of you work with eating disorders directly? Okay, great. So I just want to give you a few definitions for those of you, the majority of you who don't work directly with eating disorders, because as you know, there's a lot of cross-addiction between substance use disorders and eating disorders. So we want to be able to pick that up, not overlook it. So anorexia is defined with a distorted body image, excessive diet restriction that leads to severe weight loss, so the inability to maintain a healthy weight, an intense fear of gaining weight, and a focus, the type of behavior that they mainly focus on is restricting, but there is a subcategory who also binge and purge as well as restrict. So when you see an anorexic, as part of the definition, they are underweight. So less than 85% of expected is what's there. Now the DSM-5 has changed by dropping out the requirement that they miss 3 consecutive menstrual cycles. This makes sense because we're getting more and more anorexics who are boys first, and also interestingly, we can have a severely underweight girl who still occasionally gets a period. So I think that one was a wise choice. So it's hard to really explain this obsession that they have with being thin, but this intense fear of gaining weight affects every single aspect of their life. And as a physician, for example, my anorexic patients, when I recommend a medication to them, or when I recommend a supplement, they will go home and research and come back and say, well, I saw that omega-3 fatty acids have 50 calories in them, and so I don't want to take them because, that's just too many calories to be taking every day on top of what I'm already eating. And then I also found out that this medication is associated with weight gain. So it's a constant battle. So you can imagine what it's like if you had a young anorexic who's still at home and the parents are trying to, get them to sit down with the family and eat. It's amazing. It's an amazing experience to sit across from someone whose brain is so distorted. And you can see that distortion in PET scans, a decrease in blood flow to parts of the brain that are associated with obsessive thoughts and anxiety, etc. So again, it is can we say it all together now? It's a brain disease. Okay, bulimia nervosa. The definition here, frequent episodes of binging. The binge is described as, or defined as, eating a large quantity of food in a short period of time, usually less than 2 hours. And then that's followed by some kind of purging mechanism to get rid of the calories and avoid weight gain. The behaviors occur once a week by definition, and the purging could be vomiting, the use of laxatives or diuretics, or compulsive exercise, which, by the way, is one of the hardest to help people stop doing because it's so, accepted in society. Oh my God, I wish I could exercise like you do, When I lived in Denver, she's very public with her history of anorexia, so I'm not telling any secrets. She was not my patient. I just met her socially. But she had a history of anorexia. She was one of the former mayors of Denver's wife. So a mayor from like 3 administrations ago. So she was well known around town. And when I met her, the first thing she started telling me about is training for the Ironman. Yeah. And all the people were supporting her, and this was seen as, a healthy change and so on. And it may be. It's hard to know, really. But compulsive exercise was part of her eating disorder, and she remains very, very thin. And so, but again, it's hard to speak out against that because, the whole city is rah-rah, go. So, and then the newer kid on the block, binge eating disorder, defined as recurrent episodes of binging. I defined binging for you. Marked feelings of lack of control over eating. And lack of control, by the way, is part of all of the eating disorders. Some people say, oh, I wish I could be an anorexic because they're so controlled. They can really control what they eat. Yeah, but they can't control the fact that they don't eat. They cannot stop restricting. So they can't control restricting in the same way that someone with binge eating disorder or bulimia can't control binging. So that sense of lack of control is there all the way. Eating too quickly, eating in social isolation, eating when not hungry, and the definition requires behaviors occur at least once a week for 3 months. Okay, so eating addiction, like substance use disorder, works through the dopamine and opiate pathways. It's similar in a lot of ways to substance use disorder, but remember that the dopamine pathway is where anything that gives you pleasure causes the dopamine reward center to light up. So having a good meal causes the dopamine reward center to light up and produce dopamine. Food addiction, yeah, it does. So I choose to often refer to food addiction as eating addiction because just like the other eating disorders, it's really a process addiction. It's, the focus is not on a drug or a substance. It's really not about the food, even though we call it food addiction. And some people will say, well, I'm really addicted to chips, or I'm addicted to sweets, or fill in the blank. But I hope by now you're starting to question the fact that people say it's the substance that's the problem. It's not the alcohol that is addictive. It is the brain of the person using the alcohol or sugar or restricting or binging. It is the brain. So again, the studies that There's been a lot of publicity, and you can see that I'm kind of on a soapbox about sugar addiction, just because I'm tired of us demonizing food, because demonizing food is what starts the vicious cycle for people who suffer from either overeating, part of the eating disorder spectrum, or those who have the fear of being fat and are anorexic. But the studies really show, and most of them were done in animals, they show that the most addiction you get in the animal population is when you alternate giving the animal access to sugar and then withdrawing it and holding it back, and then giving it to them again and then withdrawing it. Now, what does that remind you of? Every diet anyone has ever been on, right? It's like, oh, I won't eat carbs. I'm not going to eat carbs because I'm on a diet. And then you do that for how long? A week, 2 weeks, a month maybe. And then you binge on carbs, right? So what I'm saying is, it isn't about the food. It's most likely about the fact that deprivation always sets you up for excessive use. So whenever you demonize a food and say, well, sugar's bad for you, sugar's addictive, or carbs are bad for you, and I mean, I've been in medicine not 50 years, but a long time, but I've read research going back 50 years, and every at least decade, we have a new food that's demonized. Fat is bad for you, right? And then it was carbs are bad for you. So then in the stores, everything was low fat, and then it was low carb. And now what is it? And now it's sugar. What else? What else are we saying? Gluten. Yeah, now it's gluten. I had a doctor in San Diego who advised that I go gluten-free. I said, well, I'm willing to try that, but I'm not sure I'm really behind it. And she got upset with me and said, well, I'll see you in 6 months. You don't need my help. And it's like, I cannot get behind that. If I see that there's a problem with me personally, then I will do it. I've been dairy-free for 8 years because dairy caused something that made my doctor diagnose me with rheumatoid arthritis. And when I stopped having dairy, my joint pain went away. So that's really clear. So there's a lot of ways to find out about that kind of thing. But, demonizing food just continues to set people up to that restrictive and then binging pattern. So again, the animals who binged on fat when it was then were restricted from it, and then sweet fat combinations, those are the ones who gained weight. And that's the same as the diet cycle, right? You go on a diet, you last for however long you last, then you go back to your normal eating habits, and you gain more weight than you lost on the diet. There's a few studies in humans, obese individuals and those with substance use disorders. We talk a lot about that dopamine DRD2 gene. This is negatively correlated with body mass index. So the heavier you are, the less dopamine you have being produced in your brain. The heavier you are, the less dopamine. And so the theory has come up of, well, are people overeating just because they're not really getting the amount of pleasure that they should be getting from the food they're eating, so they just keep eating because the brain is not producing that pleasure? Again, dopamine modulates not only reward, but motivation. So dopamine deficiency may perpetuate pathological eating. For many people, especially if you have a weight issue, you may trigger the release of dopamine just by seeing a milkshake or seeing a chocolate cake. Then that starts that process. I see some people smiling here. Am I triggering you right now? Okay. Anyway, they now have a food addiction measure that's been put together by Yale, and it's based on the substance use disorder criteria, like persisting in overeating or obsessing about food in spite of negative consequences, and so on down the line. So those who have a high score on the food addiction scale they are definitely going to be triggered by even pictures of food or smells of food, and that can trigger overeating. So, okay. So again, this is kind of just moving us down the line. Trauma leads to the addictive problems we're talking about, and also medical problems, as you saw in the ACE study. There is that strong relationship between childhood trauma and all sorts of psychological issues in later life. And abuse, it can lead to eating disorders and addictions, and that's mediated by mood disorders. And I showed you that high cortisol being produced because you're hyperactive to stress then also puts you at higher risk for certain types of depression. So it's the same, connecting the dots. I'm just reminding you of that. And I think this is an important topic because even if you aren't directly seeing eating disorders, I do a lot of consulting work with treatment centers that are mainly for addictions, and they have me come and help them identify eating disorders or set up programs for eating disorders within their facility, because it's like a third of alcoholic women also have an eating disorder in any treatment program, and vice versa. So if you have an eating disorder, you're more likely, I think for binge eating disorder, it's 50 to binge eating and bulimia, 50 to 75% also have substance use disorders, and so on. So you may say, I'm treating addictions, but the most common relapse that I see in my work is people who have addictions, who have an untreated eating disorder, and then when they're abstinent from their addiction, then they relapse on their eating disorder, and vice versa. I just had a patient recently in the treatment center I was working in San Diego. Lovely girl, wealthy family. She'd been in treatment almost nonstop for the past 2-3 years. And she was discharged and relapsed. So she has, I think, bulimia. She was discharged and relapsed on alcohol, severe relapse on alcohol. And so if you're in an eating disorder treatment center and you're not treating, really, really hard treating the substance use, even if you don't think it's primary, or as my mentor used to say, the closest alligator to the boat. I don't know. You know what? These people are surrounded by alligators. Their boat is surrounded. So we can't just pick the one that's closest to the boat because the others are just a few centimeters away. So we've really got to work on treating the whole person. And that's the perspective that I think you're going to learn about integrative medicine, that it offers you that ability. So finally, before we move into treatment, as eating disorders become more severe, the number of substances may increase. Severe binge eating disorder has consistently been associated with alcohol use. Attempts to lose weight by purging are associated with stimulant use and sleeping pill abuse, and so on. So now let's move into talking about integrative medicine and what it can offer you, even if you're in a private practice or if you're working in a treatment center or a hospital. How can this perspective help you to help your patients? First, let's look at the definition of integrative medicine, and this came out of the program in integrative medicine that Andrew Weil runs at the University of Arizona. Integrative medicine is a healing-oriented discipline that takes into account the whole person, body, mind, and spirit, including all aspects of lifestyle. It emphasizes the therapeutic relationship. Why? Why do we need to, It matters why, though. Why does it matter in this population? What have we been talking about this morning? Attachment. Emphasizes the therapeutic relationship and makes use of both conventional and alternative therapies. So we're not talking about saying, oh, don't use medication or don't use a conventional therapy. We're talking about and, not or. Okay, so This, I'm going to give you 8 cornerstones of an integrative approach, and I'm just going to go through these quickly. Again, I'll make available my slides to you. I just have to take off any patient information or patient art, which you'll see later. The basics, we need to identify patients' depression or anxiety diagnosis. We need to ask them about the stressors in their life. Think about it. How many of you are actually asking them when they come in the door, like, what is stressing you out right now? How are you sleeping? What kind of social support do you have? Number 2, we use pharmaceuticals when necessary. Number 3, integrative therapies to help with emotional regulation, deep relaxation, and integration of all of that brain stuff that you're working with them on, all of those insights. How do we integrate that into their lives so that it's deeper, it's not just on the surface? And number 4, skills for emotional regulation. We talked about that hyperactive stress response, that attachment disorder, the adverse childhood experiences all funnel into emotional dysregulation. So if we don't teach them how to regulate themselves, we're going to be in trouble. Number 5 is a nutritional program. Now, this is where we can heal the brain. If you continue to eat the foods that are in the 12-step diet, as I mentioned, that's going to make the brain on fire. And inflammation in the brain causes inflammation in the body, and it's the underlying cause of all chronic diseases. This next one is exercise, helping them to reconnect with their bodies and learn healthy behaviors. Number 7, obviously therapy for insight, food and mood connection, body image, all of the work we do with addictions and getting at the root cause, what happened when you were a child. Number 8, nutraceuticals, which are supplements used as medication and used to support medication effects, decrease side effects, so you don't have to keep upping the medication. I'll show you how that works in a few slides. So are you stuck with the brain that you have now? God, I hope not. So the brain that's been damaged by stress and adverse childhood experiences and attachment issues, there is help. So how do we heal the brain? First of all, starting with the diet. I've mentioned it on numerous occasions. It undermines brain function, increases inflammation. It also decreases brain-derived neurotrophic factor, which is a marker for brain health. So as it goes down, it means your brain is less healthy. As it goes up, it means your brain is healthier. How do you make it increase? Good diet and exercise. So good diet and exercise isn't just about how you look or what you weigh. It's about your brain. And then gluten and casein, we know if poorly digested, can create these morphine-like substances that cause us to that can play a role in autism, Asperger's, ADHD, and other mental health issues. So there are people in our culture who really have gluten intolerance. They're called celiacs. That's a small proportion of the population. Then there are people who have gluten sensitivity. And we know that exists because there are studies that have shown that you could take a person, give them anonymous food of some sort, and they don't know that it has gluten in it, and they will react to it. But then there's the rest of America who thinks that they have a gluten problem, especially in California. And so those are the people I'm talking about, that we shouldn't be, demonizing gluten. So again, the modern diet undermines brain function. The modern diet is called the Standard American Diet. What are the initials for the Standard American Diet? It's very sad. Very, very sad. And the Standard American Diet has a high glycemic load, which causes release of insulin, which makes your body go into stress and causes inflammation of the brain. We don't eat enough fish. We eat too much meat. So you have more omega-6s than you have omega-3s. And that, again, has a lot of effects. I'm going to show you a few of those, which I think you'll find interesting. We don't have a lot of nutrients in our food anymore. When I travel to places like Italy or Australia, oh, my whole body rejoices because the food is so fresh. It's, you know, you don't have to eat as much because the taste, like eating New Zealand lamb or New Zealand beef, it's like a little piece of heaven. That's all I'm going to say. It's all, you know, it's grass-fed and finished, et cetera, et cetera. You eat in Italy and you get tomatoes that just make you want to cry. They're so good. So our food isn't like that anymore. And for good reason. We had a growing nation that needed to be fed, and the farmers stepped up to the plate. But in the process, they locked arms with Monsanto and some of these other companies and used fields that were not replenished. And so our foods do not have the same nutritional value that they did when I was a kid. The food is low in pre and probiotics, high in acidity because of the meat content, and high in toxins, antibiotics, and hormones. So how do we detox the body? How do we reduce that toxic load? Well, there's supplements you can use, like turmeric or curcumin. Turmeric is one of the most potent antioxidants in the world. It's, you know, it's what's in curry. You can use it in soups, and it's been associated with reduced risk for certain types of cancers. Green tea is also a potent antioxidant, and it also has EGCG in it, and has anti-anxiety properties. Sulfur foods like Brussels sprouts, if you don't like those, go with the other cruciferous ones like broccoli and cauliflower. Those foods are, if you have them on a regular basis, they have a detoxifying quality. And then eating foods that are organic. Now, a lot of people talk about the cost of organic foods. Well, the Environmental Working Group, EWG.org, has a list of the, I forget what they call it now, the top 10 foods that you should always eat organic, and then the rest of them you don't have to worry about. So there's certain foods that tend to concentrate toxins, so those you want to eat organic, like grapes, I remember is one. But they change that every year and update it based on their research. So if you go to EWG.org, you can even get a little card that you can carry in your wallet or your purse that shows you which foods you need to pay out of pocket for organic. Juicing is really important. We've seen studies on rheumatoid arthritis where a 10-day juice fast has helped reduce symptoms of arthritis, and it also is a good detoxifying, especially the green juices. Juices made from green foods like spinach, the green leafies. And then detoxing the body, continuing with that, supplements that increase the substance glutathione, and those include the ones here. Milk thistle is particularly thought to help the liver, because the liver is the detox organ in our bodies. And then buffered vitamin C, that's another one that generally is deficient in addicts and alcoholics. And N-acetylcysteine, which helps with detoxification. Using a sauna or a steam room, you know, some of the Scandinavian countries have really good health, and they use those saunas, you know, every day. They have them in their backyards and in their bathrooms and stuff. So it does help to get rid of toxins. And then we want to identify medical conditions and mood disorders, because if you release someone from your program or from your office and say, okay, you're not using your drug, but you still have depression that's untreated, that's, again, a risk factor for relapse. So we want to make sure, you know, I have a guy now who is an alcoholic, and the biggest problem for him is his drinking, obviously. But right there up behind that is anxiety. So he's often drinking because he's feeling so anxious, and vice versa. So it's a vicious cycle, and until we get the anxiety under control, his drinking is not going to be under control. So I know that may not be popular with everybody, but if you look at the statistics, they're pretty clear. at this point. The other thing, I've mentioned a couple of times the medication-assisted treatment. We are still using methadone. I don't prescribe that, but I do prescribe Suboxone and Vivitrol. Vivitrol has some support in the research to support its use for alcoholism. Interestingly, I think there are some small studies. Vivitrol is naltrexone, the opiate blocker. There are some small studies that say that it may help with people with binge eating as well. And so, but the drinking is a big one. Now, there are all these, techniques to use, like if you take naltrexone on the day that you're going to drink, it may help you reduce your drinking. That's possible. I don't really think there are a whole lot of studies to support it just yet. But what I found is with people who are really alcoholics, you can give them the oral naltrexone, which is brand name Revia, and see them, I see them regularly in my practice. I do therapy with them, et cetera. I have them go to AA. But about month 3, they just lose it. It doesn't last. So I think the Vivitrol is a better option. I hope one day we have the Vivitrol is a shot that lasts for 30 days. And I hope at some point we have something that lasts for 6 months, because that's what we need. Again, we need to give the time for the brain to heal. Suboxone, I think, has been a miracle for many, many of my opiate patients. I've had patients who've been on heroin who've lost all of their friends to overdoses, who are dealing with the trauma and grief of losing so many people in their lives who've been raped or mugged, or other traumas have happened while they've been using. And so many of them go on to reestablish their relationships with family, to get married, to have children, and to do well, still taking Suboxone. Now, I know that according to the strict definition of NA, they are not abstinent. But I think at some point we have to do what works. And the studies are clearly showing that Suboxone is reducing mortality, increasing length of stay in treatment, and improving the overall outcomes of patients on opiates, no matter what they are, fentanyl, heroin, prescription pain pills, etc. Okay, we have testing. Remember I talked to you about the stress response and how chronic cortisol is associated with mood disorders and other problems. It's also associated with insomnia, fatigue during the day, etc. So I just want to give you a couple of little, this is a test that we use, usually a saliva test, to determine levels of cortisol. So here is the patient's result, and here between these two dotted lines, that's the normal. And what you can see is that this patient gets up out of bed already revved up, and they never really calm down into the normal range. So this causes a lot of problems. Here's another one where, these dots are the patient's cortisol levels right here. So this person wakes up in the normal range, but then mid-afternoon has the mid-afternoon slump, right? How many of you have that? And then starts getting revved up in the middle of the night. So they can't get to sleep. They're wired and tired. One of the supplements I've used for patients like this is kava kava or valerian to help kind of calm them down and get them back to sleep, or get them to sleep. Oh, there's the line. Now I get it. Okay. All right, here's another one. So let's see here. There's the line. All right, this person barely gets into the normal range at mid-afternoon or late afternoon. They're pooped in the morning. They have to get coffee to get started. Are there any of you in here like that, who can't even be civil in the morning because their cortisol is so low? So they have difficulty waking, difficulty starting the day. These are the people who need L-tyrosine. And tyrosine, I don't know if you remember, it was on that list of amino acids. And L-tyrosine is like nature's coffee. So I'll just tell you a quick story. I used to work with a woman who was like this, and I tried to get her to get off her coffee. Like, we would go on, marketing trips. She'd pick me up at 5 in the morning, and I couldn't even say hello to her because she was so grumpy. And then we'd drive through Starbucks, and she would get 2, what are those called, the Ventis? Yeah, 2 Ventis with shots in them. Yeah. And I was able to get her to try the tyrosine. It worked really well, but eventually she went back to her coffee habit. But basically, she needed, she really needs this L-tyrosine, and she needs to find out what's causing the low cortisol levels. All right. So the other thing that I do in my integrative medicine practice is to measure the level of amino acids in urine. And this measure of GABA, norepinephrine, epinephrine, dopamine, etc., gives you an approximation of what the brain snapshot is of serotonin, dopamine, etc. Now, if you're a Western-trained doctor, like I was, I have an MD from University of Michigan, one of the best schools in the nation, you'll be skeptical, and I was too. But I've been doing this test now for over 10 years, and I can tell you that it's very much correlates with what I'm seeing clinically, and it gives me a place to go, especially for patients who don't necessarily want to take medication but need help with mood or anxiety disorders. So this is one study that just shows that these biomarkers are valid and that they do help. So this is an example here. So you can see on the left-hand side, serotonin at the very top, and then on down, et cetera, et cetera. So this was a particular patient who was obese. She had a history of complicated grief, trouble losing weight. She was dysthymic and severely enmeshed with her mother with disordered eating and body image issues. And you can see this is the normal range here. So she is very low on serotonin. The GABA was at the lower end of normal. The taurine was too high, and on down the line. So a lot of things, dopamine, very low. Remember I said that people who are obese will have that dopamine rewards, the RDS, reward deficiency syndrome. So when they're eating, they're not getting as much pleasure as someone who doesn't have that. So here this is showing that she has that low dopamine and also is stressed out because her adrenaline and noradrenaline are both low. So there are supplements that we can try to help with that. This just shows you what happens with the manufacture of the different neurotransmitters. So I think I mentioned that phenylalanine we use for opiate addicts because they have that hypersensitivity to physical or emotional pain. Well, in the body, phenylalanine goes to tyrosine, which is the nature's coffee. So if there's a problem here, those are the people who might have trouble waking up. And then goes to L-DOPA and makes dopamine, norepinephrine, epinephrine, etc. So what I want you to notice here are all of the vitamins that are necessary for these processes to happen. So most of the patients I work with, particularly with eating disorders, but also with addictions, are deficient in many of these vitamins. Vitamin C, particularly in addicts, and the B vitamin for both addicts and those with eating disorders. And they may have methylation issues. You may be hearing about how people need to take methylated B vitamins. So we can measure that to see if they have that epigenetic SNP, the MTHFR one, that makes it impossible for them to actually manufacture the B vitamins. So there's just, there's a lot going on right now that we can use to help people, and it's not that difficult to do anymore. So I said I would give you a few, just examples. I don't have enough time to go through my whole repertoire of supplements, but this one is one I really like because it has so many values. So omega-3 fatty acids, everybody in this room knows what that is, right? That's fish oil. If you're a vegan, it's kelp and other things, walnuts and so on. But they're also found in foods. And we know for people with depression, if they take omega-3 fatty acids, it will help them stay in remission longer. We know that populations that have high levels of intake of omega-3s have lower levels of depression. We know that omega-3 fatty acids also are important with anorexia because omega-3s can be essential. They're called essential fatty acids because our body can't always make them. So these essential fatty acids affect zinc absorption. And zinc is likewise necessary for metabolism of omega-3s. And interestingly, zinc is always low in anorexics. When you give them zinc, it helps them to gain weight, which they don't want, of course. But what about this one? This has been repeated multiple times since 2006. And it's been repeated in the military, which has such a high rate of suicide. If you have low omega-3s in your system, it predicts the risk in depressed patients of suicide over a 2-year period. So low levels of omega-3s are related to high risk for suicide in depressed patients. So if you could reduce the suicide risk by taking omega-3s, yeah, wouldn't you jump at it? Yeah, exactly. Okay, also high risk of alcoholic fatty liver in animals is associated with low levels of omega-3s. So just back to the suicide risk, I know that the military has been replicating these studies and trying to figure out how to use them, which is very encouraging. We know that increasing the amount of EPA, I'm just going to say omega-3 because there's EPA and DHA, you probably know in there. EPA is associated with lowering anxiety. The DHA fragment is associated with decreased anger in substance abusers. Again, why wouldn't we do this? And then substance abusers with higher levels of this form of omega-3s were less likely to relapse. Okay, so that's there. So why isn't every treatment center putting that in the water? Why aren't we putting it in the municipal water? Okay, all right. So now let's segue to the gut brain. This little slide shows you something about how your body develops the right amount of bacteria and so on in your gut. And basically it's from having a vaginal delivery. So if your mother had a vaginal delivery with you and she breastfed, then by age 1 you have the appropriate amount of you have an appropriate microbiome, we call it. If, however, you were born via C-section, you were bottle fed, then you won't have that appropriate colonization. Okay, why do you care? Oh, wait a minute, come back. Okay, so here are some of the foods that you can eat, and I'll tell you why you should care in a minute. But here's some of the foods you should eat to get good probiotics. Raw milk, as a medical doctor, I can't recommend, but it is pretty awesome. If you personally want to, but the party line is you shouldn't eat raw milk. That's why we pasteurize milk, because it prevents infections. But, for example, when I lived in Colorado, they had a farm where you could go out and get a piece of a cow. You'd have like shares in a cow, and they would show you the reports where they were testing the milk to make sure that it didn't have any negative bacteria. And in that case, it was fine to drink raw milk. Bone broth and seaweed has minerals. Fermented foods are the big ones. Not fermented with vinegar, though. That's the modern way to ferment. But we want to ferment it the old-fashioned way, like sauerkraut, yogurt, kefir, etc. And then offal. If you watch any of the food shows, you know what offal is. If you don't, you probably don't want to know. It's too early in the morning. No, offal are things like that parts of the animal we don't usually think about that some cultures eat, like brain and what else?
Liver?
Yeah, organs. That's what offal is. Guts, like in the Hispanic culture, what's that? A soup? Menudo, yeah. So there you go. Okay, so why do you care if they're probiotics in your, or if you're eating probiotics, or if you have a good microbiome? This is way back to 1807, and look who he was, the father of modern psychiatry. The primary seat of insanity generally is in the region of the stomach and the intestines. Why do you think he said that? He was really prescient when he said that. Well, that's because 80% of the serotonin receptors are in the gut. The gut is called the second brain. And there's a lot of lore, cultural lore around that, like you have butterflies in your stomach, or I have a gut feeling, or, you know, we know that intuitively that the gut and the brain are connected, but they actually are connected. When you look at diseases such as irritable bowel syndrome, for example, where you have a lot of people with irritable bowel syndrome also have a lot of mood and anxiety issues. So their gut isn't working, so now their mood and anxiety comes on. And then Hippocrates, my personal favorite, says all diseases begin in the gut. So we have something called leaky gut syndrome. And the standard American diet is one of the causes of leaky gut syndrome. When you add to that increased weight, that can cause inflammation, insulin resistance, and that's the true cause of diabetes. Overeating changes the gut microbiome, and they've done studies in people with obesity, and the types of bacteria that they have are different when they're overweight or obese to when they return to normal weight. So there's something there. What do we do for it? Well, we don't want to just take probiotics. We need to give the probiotics the food to work, and those are called prebiotics. And those are things that have fiber in them. So the prebiotics support the work of the probiotics. So foods that are listed here have prebiotics, and then of course the foods I mentioned with probiotics. There is a supplement called glutamine, which also helps this microbiome in the gut. And taking omega-3 fatty acids can also help. Yet another reason why omega-3s are important. Now, I don't have enough time to go over all the studies here, but I can tell you that besides obesity, depression and anxiety are related to the microbiome being out of whack. And then other forms of inflammation that are associated with chronic disease have a relationship to the microbiome. So there's lots of great books now about gut health. And, if you are interested, there's lots of articles online about it. But if you suffer from chronic constipation, for example, then you need to work on your gut microbiome. If you suffer from chronic gas and bloating, or in any way your gut is telling you that it's struggling, then this is what you want to work with right here. So GI problems are the number one complaint in patients with eating disorders, so that's why I'm bringing this to your attention. We probably don't ask our addiction patients what their guts are doing too much, but if we became aware of that, I would wager a guess that they have the same problem. So eating disorder patients are very aware of it, and there are whole books written on it. I wrote a chapter in that book on, just how to use integrative medicine to deal with that. But it's really an important component of healing and recovery from the mood standpoint as well as the digestive standpoint. We talk a lot about mindfulness in eating disorder work. It's really moving into addiction work. I think the term is often overused and yet maybe not as well understood as it should be. The takeaway really is about how can you be more present in your day-to-day life. So just like I was talking about the mother with the toddler on her phone, how many of us are in meetings and we're multitasking? And you know, the statistics show that multitasking really doesn't work, but yet we keep doing it. We're so easily distracted. If we're in a meeting and we're bored, we grab our phone and start, you know, people walk across the street with their face on their phone. It's really interesting. So, you know, there are probably people who have sex while they're looking at their phone. I don't know. But I wouldn't be surprised is all I'm saying. Just saying. I would not be surprised. So really it's about bringing presence to your life. How does presence help you if you're a drug addict or alcoholic? How does it help you, do you think? So you can notice the triggers before they become overwhelming, and you can maybe interrupt the cycle before it goes too far. Relationships are better when you're more present. Like when you're actually listening to somebody, as weird as that may sound, you are getting more satisfaction from the relationship, and they are too. So having social support helps with addiction. You know, all of these reasons. Obviously, for eating disorders, it's really important to have mindfulness in relationship to food, because choosing what you eat, eating mindfully helps to improve your satisfaction with the food and make better choices and so on and so forth. So it's really important. And then I've mentioned several times emotional regulation and using DBT, CBT, and all the T's for that. So I'm not going to go any further there. Okay, so emotional regulation is associated with less restricting in people with eating disorders and better downregulation of negative affect. So we use things like meditation. That's been tested in incarcerated population and shown to, look at this, decrease alcohol, marijuana, and crack use after discharge, and probably while they're still in prison, as I hear there's a lot of that still goes on in prison. Decrease alcohol-related problems and psychiatric symptoms, and that's from meditating. Increase in positive psychosocial outcomes. So being present in your life, which meditation is a training for, can help with addictions. Male alcoholics in an inpatient program who practiced meditation or used biofeedback had fewer drinking days than those using neurotherapy or nothing. And that study went out for 18 months, which is good. DBT for substance use in women with borderline personality disorder had significant reductions in substance use, stayed in treatment longer, and had better social and global adjustment at 12 and 16-month follow-up. Okay, so it's better not to do meditation as a fad, just so you want to you want to put in your brochure that you do integrative medicine or you do mindfulness. I mean, I see that in so many brochures now, but it has to be a practice that's really system-wide. So, for example, when we did DBT at CR Tucson, I had to train my whole staff to do DBT, and we had to use those things with our clients on a regular basis. So you can't just throw a couple of hours of meditation at the patients. You too need to experience that. You too need to understand the benefit of that and how to use it in your day-to-day life. Otherwise, it's not quite as effective. Okay, so what do we do about the attachment issues? Well, Bessel van der Kolk talks a lot about limbic therapy, and he even has a certain type of yoga training which is for trauma survivors. And we're basically talking about yoga for trauma or any kind of movement program. Yoga can reduce insulin for those with metabolic syndrome as well, and it can help with dealing with stress. So body-centered therapies like massage can increase dopamine levels, decrease cortisol levels, increase beta endorphins, and can help with anxiety during drug withdrawal. Many of you know of the NIDA protocol, which I've used in my practice, which is ear acupuncture that was used for withdrawal from heroin back in the late 70s, early 80s in Harlem. And it's still around, so that's one of the ways that we can help people deal with their withdrawal symptoms. And then, of course, attachment is well treated if you're able to establish that secure relationship with good boundaries with your client. Many of us who are in the treatment field have ourselves had attachment issues or adverse childhood experiences, so I always want to emphasize that it's important for you to continue doing your own work, so that you don't have boundary issues, so that you don't step over the line with people. And then these are the levels of recovery that I work with my patients on. Again, when we look at the top of the iceberg, we look at the tip of the iceberg, we're looking at the superficial level of behaviors. So that's this level. That's what gets everyone's attention, and we can feel really good about ourselves if, oh my goodness, they stopped using. That's so great. I'm such a great therapist. They had these big insights. Wow, look at me, I'm rocking it. I train a lot of therapists at these treatment centers, so I've heard these. I'm not making this up. I've heard this. They don't say, look at me. They just said, oh, you won't believe what happened. This person had this great insight. And then I'll say, did they stop using did they stop binging and purging? How is their emotional regulation, et cetera, et cetera? Because we can't just stop at this tip of the iceberg, because that's what leads to relapse. We got to help people deepen their recovery. And anybody who's been in long-term recovery and has really worked the program knows that it has to do with dealing with these emotions that trigger the behaviors. It has to do with reconnecting with your body and understanding how to pick up when you feel fear or anger in your body before you rage on somebody or blast somebody with your voice. And then we have to identify the core beliefs that are driving these behaviors. So what's an example of a core belief? Well, I had a patient long ago now who had binge eating disorder. He was a big guy, and he was working for his wife's company, and the wife was very wealthy. And so every time he would get his binge eating under control and lose weight, he would become very anxious, and then that would lead to overeating again, and he'd gain the weight back. So when we were going through a process to discover the core beliefs, and this process I describe in all of my books, and I have a lot of therapists who use this from the book to help people identify their core belief. I found out that he had been asthmatic as a child, so he was kind of puny and weakly and sickly, and his older brother, whenever they would get into trouble, his older brother would just go into his room and start, I'll show you, and pound him. And then when Scott became 16, he was now taller and bigger than his older brother. So one of these episodes happened, the brother came at him, and he got so angry, he tore the bedroom door right off of the hinges and scared the bejesus out of his brother. And in that moment, which he had totally forgotten, in that moment, he formed the core belief. He had the thought, bigger is better. Bigger is safer. So he had totally forgotten. He's now in his late 30s, and he's still feeling unsafe whenever he loses weight and he's in the relationship with his wife, who's the financial heavyweight, and he works for his wife's company, so he's vulnerable there too. So the only way he felt safe was to keep the weight on, and that's what Folletti was telling you about in the ACE study. And then finally, I think the most important and deepest level of recovery is really connecting or reconnecting with the deeper urges of your soul, your spirit, your authentic or true self, which can be covered up by all this other stuff. And once you get down here, then this part of you starts running the show. This part of you forms core beliefs and connects with the body and manages their emotions and doesn't have to white knuckle it through the behaviors. Does that make sense? Okay. All right, so finally we've talked about genetics, and what's revolutionary about integrative medicine, this was what do they call it, an opinion piece in the Wall Street Journal, op-ed, with my mentor, Andrew Weil, and Deepak Chopra, and a few other famous guys. And they said that integrative medicine approaches such as plant-based diets, yoga, meditation, and psychosocial support may stop or even reverse the progression of coronary heart disease, diabetes, hypertension, prostate cancer, obesity, high cholesterol, and other chronic conditions. We have proof of this. This isn't just a theory. Dean Ornish has shown in study after study after study that he's reducing atherosclerotic plaques in the arteries through diet and meditation and stress reduction. So it works. So we can minimize our genetic issues through integrative medicine. And then finally, long ago, I myself suffered from a chronic medical condition. I was diagnosed with chronic fatigue syndrome and fibromyalgia. And during that time, I was unable to work for 2 full years. I learned a lot about healing, though. I met all of these people who had healed themselves through multiple different modalities, some of them through reading a book that someone had suggested to them, or alternative medicine, or going to Mexico for, fill in the blank, etc., or used Western medicine or a combination. And some of the things I learned from them is, first of all, illness is a call to action. It's a call to change what's not working in your life. And it's really a call from your spirit, your higher power, whoever God is for you. And there are many roads to healing. We don't have to just do one thing. We can do multiple things all at the same time. And in all situations, it's best to choose the thought and action that makes you feel the most whole. So the other thing that I work with my clients on are rituals and rites of passage. And that whole concept of that is integral in integrative medicine, the concept of self-healing. In Native American culture, they have the vision quest, which is a transformative experience. We don't really have anything like that, but we do have myths and metaphors. So this is one of the pictures that an eating disorder patient drew to describe the difference between what it felt like for her to be in her eating disorder and what it felt like for her to be in recovery. And even though this is all pink and blue and yellow, this is really like very safe, and it feels protected. So you can see that there's some attraction to this, even though the light, is over here. So it's really about looking at what the disease represents to them and how is it helping them. So Joseph Campbell, who is no longer with us, but has written a lot of wonderful books about myth, says myth is the secret opening through which the inexhaustible energies of the cosmos pour into human manifestation. So I think, what I've tried to portray for you today is really the understanding of how life has come together in all the different things that our patients go through to affect the brain's development. And I've given you a little bit, I hope, a little bit of a clue that there are ways for us to help the brain heal. And only through healing the brain and through treating people for the long term and helping them to mend their families and their relationships and so on, can people really reach that deeper level of recovery that I think all of us want for them and that they want for themselves, whether they know it or not. So I'll stop now and take any questions that you have. And I think there's a microphone if you have. Yeah, back. There's someone in the back there. Back row.
Hi, thank you for your presentation, first of all. And the second is, in your discussion of the attachment, it sounded exclusively regarding the mother's attachment.
No.
Where does the father fit in?
Whoever the primary caregiver is, and I'm sorry if I gave you that impression, but it could be a grandmother, it could be a father, but whoever the primary caregiver is who the is the attachment person for that child. So could be a stepmother.
One more here.
Thank you. In terms of adding the over-the-counter L-tyrosine and other like homeopathic or other medications, is there a concern in terms of how those would interfere with the psychotropic medications? Do we need to be aware of things that would have negative impacts?
You do need to have a little bit of awareness of that. There's lots of good resources online now that you can use that will show you the interactions between them. Or you can refer to functional medicine or integrative medicine physicians for that piece. If you want to, I have a friend who's a nurse practitioner in Denver, and she started working with me, and then she was able to take over with her patients after some interactions because we worked with patients together, and that's how she learned. But there's lots of good resources now on that.
I have a patient who said to me, I go to these workshops and stuff, and there's genetics involved, so I'm screwed forever, and it's my mom's fault. How do I reply to that?
Well, I gave you that last slide. That was the op-ed piece in the Wall Street Journal. So look it up and make a copy, because it's basically saying through the use of integrative medicine, through changing your diet, stress management, dealing with your emotions, that you can change your genes.
So I have acknowledged, your childhood sucked, but now you're an adult who can take control
Yeah.
of certain parts.
And remember also, it's not 100% genetic. There's a big portion of it that's not. Even when it's 70%, you still have 30%. But we are able to minimize that genetic impact through the use of integrative medicine.
I've actually heard it put well, which is genetics loads the gun, but you don't have to pull the trigger.
That's right. Genetics loads the gun, but you pull the trigger. Yep.
Thank you very much. You mentioned DID. How are you differentiating between DID and depersonalization? And this is a coping mechanism where someone doesn't feel safe in a situation or in their body. How are you treating that?
I am not a specialist in DID. I have worked with patients with DID, but I think they're very difficult to work with unless you have that background. So I don't know that I'm the person to answer that question. I can give you the benefit of my experience. Like I said, I've had a number of patients, but and it is, I agree, it is a coping mechanism that has come about usually because of severe trauma in childhood.
What's DID?
Oh, dissociative identity disorder.
Oh.
Yeah, what we used to call
Multiple personality.
multiple personality. Yeah.
Depersonalization is a lower level than that. Somebody who's trying to get out of their body and
Yeah.
isn't necessarily manifesting multiple personalities, but isn't in the situation.
Yeah, I have a friend here in Malibu who is, a specialist in that, and she has taught me a lot, but I still find it a very difficult problem to work with. Challenging, I shouldn't say difficult, challenging.
One of the slides mentioned the testing for the amino acids as well as the neurotransmitters. And is the amino acid testing something that a primary care doctor could order? And can
Yeah.
you explain, I'm not aware of how the testing is for neurotransmitters except through the brain imagery.
It's really through those amino acids. That's what they're saying, through the excretion of those amino acids in the urine. So they're usually urine tests. Now, I used to use a company that I've used for 10 years, and they just are in the process of changing hands. So I can give you their name. They're probably going to be back online at some point. But the other company that has a similar test is called Great Plains Laboratory. And all you have to do is go online to Great Plains Laboratory, and you set up an account with them, and they'll send you a kit. And the kit will have instructions for the patient on what to do, and they'll bill insurance for some of them, and for the ones that they don't, they offer a pretty good cash price. So it's Great Plains Laboratory. And if you have any trouble reaching them, I think my email address is on the first slide. Let me go back to that. If you have any questions that come up that you want to have answered.
Is your email on your book, on your workbook?
No, I don't think my email is on that. But it's crossmd@mac.com. It's in here somewhere. Take me a while to get back to it.
One more question here.
Yes.
Yeah, my question has to do with a patient's relationship with money. If someone has, say, a gambling addiction or a retail therapy addiction or just avarice, the concepts that you talked about, do they apply equally well?
Absolutely. So many, and also what we call love addiction is one that I didn't mention. Those process addictions are also co-occurring addictions with eating disorders and substance use disorders. See a lot of shopping addiction in our eating disorder clients for sure, and the same for addictions.
Okay, well, thank you very much. Let's give Dr. Ross a hand.
Thank you.
Appreciate it. See you all in 2 months.